again, what is the rationale for considering using local therapy for metastatic disease beyond palliation? I think the improvement of systemic therapies, the idea that even though we have improvement in systemic therapies, they're still not perfect and often do not stand alone. The idea that modern diagnostic tools, including imaging, can help identify patients at earlier stages of metastatic disease, and hopefully with screening mechanisms help with that process as well. So the idea is there a potentially chronic or curable subset? More data to support the use of local therapy. If we look at patterns of failure, what group in Colorado and others have shown is that the original sites of disease that patients have are usually the first sites in which failures occur and progression of disease occurs. So the question was, why not consider employing local therapy if we know more likely than not where the first sites of failure are going to be in the body? And this is what again led to this kind of innovative hypothesis that Hellman and Wexelbaum developed in the 1990s. But we actually have now significant data to suggest that this may be actually helpful. One is we have to look and congratulate our surgical oncology colleagues who, for years and decades, were aggressive with metastatic sarcoma and colorectal cancer that went to the lungs, for instance, or the liver, in resecting those aggressively and still treating patients with a very much a curative approach in the stage 4 setting. The same was done with metastatic non-small cell lung cancer that had isolated adrenal lesions. And then, of course, neurosurgeons have historically been aggressive when necessary for limited metastatic disease that's gone intracranially. And all of those studies suggested actually a benefit in survival, not just a benefit in symptoms or progression-free survival, even some suggested overall survival. So again, the ideas for using local therapy in metastatic settings or limited metastatic settings. Chemo-IO studies don't really describe patterns of failure, but in general, failures occur in first sites of disease, and responses last but don't last forever. And so that's kind of the direction that we started taking to think about this as a field in radiation oncology. It happened to coincide with the evolution of SBRT, and I hope a lot of you have heard about SBRT. It is a highly conformal, image-guided way of using radiation to treat specific depots of disease in the body. It's non-surgical. We can literally use SBRT to treat sites from the top of the head to the bottom. And quite honestly, SBRT has, if used appropriately, limited toxicity, and it was more or less perfectly suited to treat metastatic disease because, as I said, there was limited anatomic constraints as long as we followed, appropriate protocols.